Thanks for listening to the Pharmacy Podcast Network.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hey, listeners, welcome back to the Pediatric Pharmacist Review. I am one of your hosts, Justin Cole, and I'm here with Mary Vuong. Mary, how have you been?
Doing really well. How are you? It's quite chilly in Miami, which is kind of weird. We're at a very chilly 51 degrees, but I'm suffering. How are you?
Well, yeah, doing well. Not too far north of you, I think there was even snow in Florida, which is crazy. But so today I am really excited about not only our topic, but our guest. You're used to hearing one guest, sometimes two guests, but today we're going to really hit you with three. So today we've got Jenna Quinn, our own Jenna Quinn, who often is a host on this podcast, joining us. So Jenna, thanks for joining to talk about our topic today.
Thank you for having me. I'm pumped, guys.
And then we also have Lisa Bimpasis joining us. Lisa's been on the podcast before as well, so we're excited to have her back. Lisa, thanks for joining us.
Thanks for having me again. Happy to be here.
And then last we have Rachel Meyers. So Rachel, we're glad to have you on here as a guest for the first time. So I guess I'll just let you start by introducing yourself to our listeners.
All right. Thanks, Justin. This is Rachel Meyers. I'm a pediatric pharmacist, obviously, and I work for Rutgers University, the School of Pharmacy, and I practice mainly in the pediatric ICU up at Cooperman Barnabas Medical Center in North Jersey. So I'm a Jersey gal, just like Jenna.
And she was my teacher. Massive amount of respect for Rachel. And when you're in the thick of it as a student, you don't really understand how amazing your teachers are. And when I got out and realized wow, Rachel's making waves in the peds world. Just thank you for being a mentor, helping me learn pediatric pharmacy and knowing me when I was a little brat of a student. You don't really there's been a lot of hopefully personal growth too since you've known me 13 years ago. But in all seriousness, thank you for being a fabulous mentor. And what I didn't appreciate as a student is that Rutgers is so strong in their pediatric pharmacology and their electives. And had I gone to many other schools, I wouldn't have even been exposed to peds and I wouldn't be where I am today. So thank you so much, Rachel.
I promise I didn't pay her to say that. But Jenna, we always love when our students end up doing pediatrics, and you have been so inspiring for us. And just so everybody knows, I did bring her back to campus to meet with a whole bunch of our students and to tell them what she does now. So
it was fun.
Yeah, that's great stuff. Lisa, why don't you go ahead and introduce yourself as well?
Thanks, Justin. And just to comment about that, Jenna, what Rachel said is true, is I'm also faculty. And when we get to see our students take on a passion that we share and change our practice, it is unbelievable. And it's why Rachel and I do what we do. So yes, I'm also faculty, but at the Southern Illinois University in Edwardsville. My practice is at SSM Health Cardinal Glennon Children's Hospital in St. Louis, is where I really live, not over in Illinois. And I am a pediatric pulmonary pharmacist.
Yeah, thanks, Lisa. And we're so glad to have you back on the podcast. So you're probably wondering, so what is this topic that we have three guests for, and why is it so important? Well, today what we want to talk about is having the patients wait on pediatric prescriptions. It's a big topic to cover, but we've got the right people here. Lisa and Rachel have both contributed to a article that was published that was part of work that came out of the Pediatric Pharmacy Association, along with some other colleagues. And Jenna and I have actually both had some experience going to our local either legislators in our states or state boards of pharmacy to advocate for this practice. So I'm excited for our conversation. I guess we should just dive right in. Sound good?
Justin, should we actually make this even more fun? Should we make you a guest also and have 4 guests?
I've never done both sides of the mic before, but hey, I might be able to chime a few things in there. So,
okay.
Well, let's start with Rachel and Lisa. So maybe Rachel, you can start by answering this question. So, what motivated you and your team to explore the issue of including pediatric weights on prescriptions?
Sure. So I think most of us who work in pediatrics work in the inpatient setting, and we're very used to, always having that information available. In fact, a lot of the electronic medical records that are out there today don't even allow you to verify an order if the weight isn't in there because they need that dose checking software in there. So I think what really began to, make me notice the difference is when I had kids of my own. And, I had to fill prescriptions for them, and just thinking about, as a pharmacist, the difference between what I see on the inpatient side when I'm looking at an order and what our community colleagues see on their end. And they really don't have the information that they need to really correctly check that prescription. Whereas on the adult side, as we know, it's usually standard doses. So there isn't that calculation issue and that checking issue going on for the adults. So I think that's where it kind of just struck me as such a big difference. I have had retail pharmacists, I will say, ask me how much my kids weigh. And I was just like, it made my heart happy. And I promise I didn't tell them that I was a pharmacist before that happened. But I think that's a rarity in today's world, unfortunately. And so I just really felt I wanted to help advocate for our community colleagues to have the information that they need to do the job that they have to do.
That's great. So Lisa, I'll let you answer that same question. What motivated you to get involved in advocating for having patient weights on pediatric prescriptions?
Rachel gave the best answer, and I found Rachel. So it was a mid-career, aspiration when we sit down and we make our goals, right? And, my 5 and 10-year goals when I was a resident or new practitioner were very different than once you've arrived in your practice and you're happy with your academic career and fully promoted. Where I was like, well, what do I have left to do? And what I have left to do, I want it to be a federal regulation that weights are on prescriptions. And who do I need to help me do that? And I got to fortunately work with Rachel on another big project, and Rachel makes things happen. So I pitched the idea to her, and a year later, we have a position statement from the PPA that hopefully all of our colleagues in any setting can use and take forward to their legislators. And my goal, of course, I said before I retire, we need to have this be a federal mandate. So let's keep going. Yeah.
So that's like a big, serious thing for it to be a federal mandate. Why? So why? I know that we know why as Pete's pharmacists, and we're obsessed with having the weight because we know how important it is. But just for our listeners out there, what are the main safety concerns that we do have for pediatric patients when prescriptions are issued without their weight? What happens?
I do think the main safety concerns are always two-sided, that we first talk with the toxic side. So if you provide a dose that is well over the recommended milligram per kilogram range, the potential for adverse effects is there. And depending on how far above that window you go, toxicity can be very concerning. And then flip over that coin where underdose, if you don't have enough of the medication, we won't have the effect that we need to treat that indication. Works both ways. And of course, we're most concerned about the toxicity side, but we also want our child to be effectively treated too.
Yeah, I think we all recognize that while pediatricians are wonderful, we all work with them every day. There's a lot of math involved, in these doses. First of all, another one of my pet peeves is how most of the antibiotic concentrations are per 5 ml, which is an extremely old-fashioned thing. And I've been advocating, I'm on a committee with the CDC, and been advocating for them to help us stop that, because that's one more math step that we don't need. And again, pediatricians are human too, and they make errors. And I think, I'd like to help them out and help out our patients by providing another layer of safety so that our community pharmacists can check those med doses.
I think too, like my biggest bugaboo as we take care of these really medically complex kids is that like the polypharmacy is rampant, and we're going to make polypharmacy worse if we're obviously causing an adverse drug reaction, which then is causing a prescribing cascade because we're adding more drugs on to treat the side effects. Or alternatively, if we're subtherapeutic in a drug and then we're just adding on more and more drugs, like it's a lose-lose in every situation. And doing this on a scale of now, it's scary, Mary, thousands of patients in the AmCare space, that is the problem. The problem is that like there's no checks and balances in place, and it's so much more of a problem on a population health level that any payer, parent, provider is aware of. And, that's really been the goal of what we're doing today, is to bring light to that. But again, it starts we're at the pharmacy, and if you can't check the weight on the script, you don't know what you're giving, what kind of dose, and then polypharmacy becomes rampant.
Yeah, and they're kind of at the last line of defense too. Like retail pharmacies are the last safeguard before the parents go home. So like just this week, I had an adult-sized child getting super underdose of Keflex for like a finger, and the child was getting very agitated and biting the finger, and he had been on antibiotics for a whole week, and it was still disgusting. So then we escalate to something with MRSA coverage when really we should have just optimized the dose for MSSA.
Well, Mary, you tell a story, and I think that's what really highlights this issue for me. So, Rachel, you mentioned that being a parent and a pediatric pharmacist changes your perspective, and that has been the same for me. I have a story where we were visiting my parents in the Southeast Ohio, and my son ended up needing an antibiotic prescription. It got called into the pharmacy, and I ended up getting that prescription in my hand, and I looked at it and said, that is the wrong dose for my son. Like, I don't know where this dose came from, but that is wrong. And so I talked to the pharmacist and said, can you actually call the doc back and get this clarified, because this is not the right dose, right? And so for many of us as parents, we have those stories, but we may also have stories from patients we've cared for. So maybe I'll go to Jenna first. Are there any stories of wrong doses that were based on a pharmacist not having a weight that really stick out in your mind?
Yeah, I mean, it's happened in all three of my children. So one was the wrong dose and frequency. So we're all pediatric pharmacists. Strep A, for some reason, is really hard for everyone to get on the same playing field. So, like, it's dosed half the dose because obviously it's not resistant strep pneumo or H flu, and then it can be dosed once a day. And it's maxed out at 1,000 milligrams a day. So one of my kiddos, they didn't have their weight, but it went over the max adult dose and was twice as frequent as it needed to be. And I have those types of stories for all my children. And again, Rachel, I am shocked you've been asked your child's weight at a pharmacy, because it's like a sick game that I play with all three of the kids in 8 years. Not one pharmacist has ever asked me my child's weight. And so I think you're a unicorn that somebody did, but that's definitely not the standard of care like I've seen in the U.S.
Yep, that's definitely true. That was only one time. And once I experienced that, I went to that pharmacy for as long as I could.
So, Rachel, as far as stories go, are there any that stick out to you about an error that was maybe preventable if we had a weight on a prescription for a kiddo?
Sure. I can think of one actually that I didn't even catch. One of the pharmacists that I work with at the hospital happened to catch. So we had some medical residents who, and again, this is where these errors happen. These are learners, right? They're still figuring this out and gaining their experience. They wrote a dose of an oral antibiotic, and the patient had been on the IV version, and they didn't realize that the doses were not the same for IV and oral. And they sent the patient home on the IV dose, and it was 5 times more than it should have been. So the pharmacist that I work with recognized it because they had put the order in somehow to get a dose before they went home. And she called, and we realized that the resident had sent home, I think, 3 patients that day. It was like a big discharge day. Same mistake on all 3 patients. So the attending had to call all those families. Some of them had already filled the medication. And again, those pharmacists in the community setting would not have had any way of realizing that that was an overdose because they didn't have the weight. The pharmacist that I work with that caught that, she had the weight because we were inpatient. It just, to me, it's always struck me the difference between the landscapes, right? Like in the hospital, it's so controlled. We have so much information. And then you go out into the community space and it's like, you're going out into the wild. Like there's no information. There's no even weight. Weight is like the most basic thing we have to have inpatient, and it just doesn't exist in the outpatient world.
So what about you? Do you have any hallmark examples?
Yeah, I think we've all described like antibiotic issues because it is the most common class that's prescribed. And I also think what's unique about this issue is, again, like Rachel and I work on the inpatient setting where it is required for us to prescribe or to verify orders to have a weight. You can't even order a medicine until a weight is put in. So it is a rarity for it to happen in our setting, and we are going to miss it on the transcribing or the e-prescribing on the outpatient side. So to come up with examples, you can tell we're either using personal examples or these discharge examples. And so, yeah, I'm going to have another example that's a little unique where there are medicines that are used in children that aren't weight-based dosing, but clearly tenfold errors if you don't give the right formulation. And a patient required an admission after a community pharmacist filled an aripiprazole prescription for 20 milligrams when the child should only receive 2, right? And so the child received 20 milligrams for several days, and we're talking like an 8-year-old, where when he was admitted, he had zero control of the movements of his body and drooled for 3 days straight until that medicine left his body. And I think it just goes to show that if you are unfamiliar with verifying and checking orders on the community side for things as simple as antibiotics, the amoxicillin and the cephalexin, versus all the way up to something so concerning like an antipsychotic, we need to stop and we need to look at drug monographs. We need weight. So that we should really talk about how we fix this because it can be so harmful.
Oh, I had 2. Mary, I shared with you to double check. Mary's our guru for neurology, and I wanted to double check because it happened with 2 different patients. So both Keppras, one was 110 mg per kg per day, and the other was 117 mg per kg per day. And I was like, have you ever in your life seen? And then I didn't even tell you about this one, Mary. The patient had a movement disorder. The gabapentin was close to 90 mg per kg per day, and the Sinemet was close to 42 mg per kg per day. And I'm like, and it was that day, all those doses that I'm throwing out in mg per kg are really high-risk drugs that could cause a lot of harm. And it was all in the same day that I identified them on some of our patients.
Wild, because normally for Keppra, I rarely go above around 60 mg per kg per day just because of the renal toxicity and the agitation and stuff. But gabapentin too, 50s, 60s, but that's wild that they were around 90 mg per kg per day. So just piggybacking off of that, we talked about antibiotics and antipsychotics, anti-seizure meds. What are other high risk meds that the community pharmacists should keep high watch on when it comes to mg per kg dosing?
Can I just make a quick point too before we get into that? And that is that I think if we add weights, I want to make sure we talk about the fact that you can then integrate dose checking software. right? And that is just not doable at this point. And I think, it helps the pharmacist out, right? Yes, they should be doing the calculations on their own, but the ability to integrate that kind of software into workflow is just another layer of patient safety that can be added. So.
Shameless plug for us, I guess, is that Jenna and I are working on our dream EHR right now, and that's one of the things we're integrating into our EHR for perfecting peds, just like the ability to do like mg per kg dosing.
Yeah, I completely agree because, if you can use any of that clinical decision technology moving forward with artificial intelligence that already provides a dose check, if weight was already there through the transcription process. I mean, not that I want to take away the responsibility from a pharmacist to double check that. Please do so, but it's not a hard ask anymore in the world of technology. It is not. Back to Mary, your original question about drug classes. To me, it's any class can be toxic. So yes, we can call out the types of medicines that would harm someone and potentially have mortality if you took too much to a child, where you want to call poison center for. But all the simple antibiotic recommendations that you guys all went through, you're going to have diarrhea from that, or it's not going to treat the infection. That's a problem to me. That causes more medical need and more cost. So I don't feel we need to call out any specific classes because it's all a problem, and weight should just be on every prescription.
Lisa, to your point, if we look at poison control center data, acetaminophen is still on the list all the time when it comes to toxicity and calls to poison control centers. And yet we think of that, at least in our society, as being such a benign pain killer or fever management agent, right? And so to your point, it's everything. That's why we need it to be a standard on all of these scripts and not just a nice to have. This is really vital information that's necessary for the pharmacist to do their job right.
Can I add to that remember that acetaminophen dosing for infants does not have the dose on the bottle? Another one of my pet peeves. We're hitting them all today. And so, the pharmacist in that case, usually, like you said, it's OTC, but would need to know a weight to help, a parent pick a right dose.
Or we could just go and talk about the 2 concentrations of ibuprofen. That really creates heartache for me as well. But you need to not only know the kid's weight, you also need to know what concentration the parent's pulling off the shelf. And if any parent, whether it's through perfecting peds or, I've become the community pharmacist, peds pharmacist for I think my kid's entire school, I won't give them a dose of ibuprofen until they show me the bottle. So there's so many problems we've into one, and it's all, and it could be, like you're saying, as simple and benign as an over-the-counter.
So I would love to transition to some of the issues and pushback that I've gotten in talking with other pharmacists about this idea of including weights on pediatric prescriptions. One of the pushbacks that I've heard most, and this is from some pediatric pharmacists, is, well, won't people just put in any random weight, an inaccurate weight, just to push their prescription through? Or what if the weight's wrong? That's a risk if we require the weight. How would each of you respond to that pushback that maybe we're not ready for it because of the potential for errors? I want to see if you say the same things I've said.
Oh, I feel like we're being tested here. Yeah. I guess I would say that there's always the chance for error in everything we do. And I think, I guess I don't think that's a good way to think about this safety measure. Yes, people could put in the wrong weight and it makes a wrong calculation. But if it's on the prescription, maybe the parent will look at it. Again, most things are e-prescribed today, but I don't think we should not do a safety measure just because there could be mistakes. I don't know, that's my thought.
Those are great answers. And I've said similar things. I think the only things that I would add to that is to say, number one, let's not let perfection get in the way of progress, right? It's kind of what Rachel has said. This is going to infinitely increase medication safety for kids. Is it perfect? No. there can be, just like we know with anything else related to med safety, we think of the Swiss cheese model, right? There's no one slice that does everything. But let's add a slice of Swiss cheese that helps to prevent some of these errors from actually reaching the patients. And then the second thing is, that comment comes, I think, from a stance of not entrusting professionalism to our healthcare professionals. I would say the vast majority of people are not going to do that, right? They're not just going to put a weight in to speed things up. They truly do care about their patients and want to do what's right. So to me, that's a poor excuse for not making progress on this issue.
Also, just there's so many ways to validate it. Like you can visually see if someone's weight matches. And something like this actually did happen to me in the hospital. I remember going on neurosurgical rounds and like I had checked the mg per kg dosing for a neurosurgical patient. She was about to go into surgery. And when I looked at her, I was like, she's tiny in that bed. Like she's much smaller than me. There's no way this girl weighs 75 kilos. So I went back to my desk, looked back at her historical weight, and she was more like in the 30s, 40s. So I literally ran, like, because they were about to take her down to the OR. I ran to her room and tried to stop her. And I'm like, you can't take her to surgery. Like, they're going to sedate her and stuff on 75 kilos. That's not her weight. Reweigh her. They reweighed her. She was like more like 37 kilos. The mistake that happened was that they weighed her with the wheelchair on admission. So it was that 40-something kilo was the wheelchair. So like that happened in a hospital setting where I was able to visually see the patient on rounds, but still in the community setting, you're able to see the patient. And if you have like issues with like the weight not really matching the age, you can also ask the parent. Like, again, there's so many validation measures. You have the parent face to face.
And even if it's like within that 10% window, it's still better than, most parents can give you a pretty close weight on their child. Maybe not height, and I'm speaking for myself, but I could get very close to the weight.
Well, Mary, you bring up a great point about inaccurate weights. And one of the most common errors that I've seen and caught a number of times in the hospital is weights being put in pounds instead of kilograms. And that can account for over a twofold change in your dose, right? So, Lisa, what were your group's thoughts about the units that should be included on those weights? Should that be standardized? What would you recommend if we were to move forward with this across the U.S.?
For sure, in kilogram, it is, well, my husband is from Greece, so he makes fun of our systems and units of measurement daily. Driving, we drive wrong in miles. I get it. And so it should be standardized for kilogram. It is the universal unit, international unit, which would require some education. I think back a little bit to your last question about barriers. I don't know, what is the percent of households that have a scale in their house? I'm sure it is roughly large. It may be inequitable. I don't know, but everybody probably has a scale of some sort. I mean, shoot, my dad's a pharmacist. We had the one that you had to move the weights, and that went from 3 houses. We carried how many pounds of scale from house? That is ridiculous. So anyway, yes, kilogram to answer your question, and requiring education and to parents and caregivers about the difference between pounds and kilograms. And I love what Mary said. Yes, pharmacists are capable of an average eyeball. And if they're not, I know I teach about growth charts. Keep a growth chart by your verification station and look at what an average 4-year-old should be at that 50 percentile. It's still an estimate, but it's better than nothing. It really is.
And then just talking about units, what are your thoughts on maybe even adding height?
It would be great, but I feel like we should fight one battle at a time. That's what I think. It's like, just start with what we need the most. Adding to like the things that I've constantly heard as far as people that surprisingly are lobbying against this is the fact that it will delay care. And I am totally okay if it delays an outpatient script by a couple of hours if it's going to save the patient's life. That's one that I've heard repeatedly as well.
We do recommend in our TPA statement to have height added in centimeters, since some medications are dosed in body surface area, specifically chemotherapy. It is required for many agents to have body surface area calculation, and you would want that for any child that would be getting that type of medicine. But I agree with you, Jenna. I mean, in my perfect utopia, the prescription federal requirement would have weight in kilograms, height in centimeters, allergy information, the indication, and the volume calculated. Back to Rachel's point about per 5 mils or per mil, if our residents don't write the right formulation, then how do we know exactly that they figured out the right milligram amount? But if they put the milligram and the volume, it is a for sure check in verification. So, but I can't have my utopia, and I start with weight as the priority, yes.
So another thing that has come to mind recently for me around this issue is I agree wholeheartedly. This should be federal legislation, right? This should be across all states. This is not a moral issue or something else that states have the freedom in our country to kind of decide on their own. This is just a simple safety issue, right? However, that's a hard road to make progress on. And so we've had to start at different state levels. Jenna, would you be willing to share a little bit of your experience in New Jersey and whether there's been any progress on this issue there?
Yeah, so we introduced, I networked my way up to one of our legislators in New Jersey and his team, and basically cold emailed them and said, this is an issue. Are you aware? I also sent them our findings from our first 100 patients in long-term care and said, here's the risk. Like, what really I think sadly gets a lot of C-suite attention is when you put dollars to something. So sadly, I said, if you have a peds pharmacist that's verifying weight and in their longitudinal care, you can reduce hospitalizations by 44%, save roughly $11K. We're finding actually closer to $24K annually a child. And this is with putting the right precautions in place. So that was like the first thing that kind of got their attention. And then little did I know they all had children. And so they were kind of mortified and shocked when they found out that that's how medications are dosed, and that many people, the lay people, are not aware of that. That is not something that a lot of people know. So once they found it out in New Jersey, they actually allowed us to introduce 2 bills. So one was to have anybody less than the age of 18 years of age that they would have their weight on their script. It would be mandatory. So that was one that we were able to introduce. The second one was that I was able to talk to them in a meeting live and just communicate with them how important comprehensive med management is in these these complex pediatric children and or population, excuse me. And so we have the one that mandated CMM in medically complex kids went first through the House. So I didn't know, but I showed up in Trenton and they told me to get on the stand and testify. So I got up and I specified why children who have medical complexity should have a pediatric pharmacist on their team, and that was actually unanimously voted through the House, which is really exciting. So that went one step in the right direction, and then I'm going to do the same. It just has not come through the House yet for the weights on scripts. But we have been, which again led me back to Rachel, which has been, every once or twice a year, we're connecting about some sort of pediatric medication change for the better. But I have realized that she had written a statement and for PPA about weights on scripts. So I've been trying to collect as many organizations as possible to really support the weights on scripts. And it has not been hard getting, PPAs, the Pharmacists, the Pediatric Pharmacists Association, AAP, the American Academy of Peds, NCPDP, keep me correct on my acronyms, and then the ACCP, the American College of Clinical pharmacists are just some, and I know I'm forgetting others that have written a letter of support for these bills. So the support's there. And I agree, starting at a state level, just given that it's kind of easier to network your way through if you can get the right connections versus getting this done at a federal level, which I agree would 100% be my ultimate goal.
Kind of since we don't have it mandated yet and it's not federally mandated for our retail pharmacy friends, what are some practical steps they can take into preventing med errors because it's not mandated?
So I think the easiest thing is to ask them to just ask the parents the weight, and then they can double check that way. But the problem with that is, or not problem, but the issue with that is that the parents mostly know their kids' weight in pounds. And so just being ready for that and, remembering to do the dose conversion or the weight conversion into kilos. You could also suggest just having a scale in the pharmacy. That's, not that novel of a concept, but
we have other scales, right?
Yeah.
We have to have the other scale. Just get a bigger one.
Yep. So anyway, just a couple of things, and again, like I said, I've had the experience where a pharmacist asked me what my child's weight was, and I was just so impressed with that. And that to me told me that she valued the safety of my child and that she was giving everything a second look. So I appreciated it.
I think education plays a key role in it too, because a lot of parents have no idea why you're asking. So that's how we start a lot of our visits. I ask them what their most updated weight is, and they're like, "Why do you need to know that?" And I'm like, "Well, did you know that most of your child's medications are dosed based off of the weight?" So just empowering parents and educating them to know that the weight is very important will then kind of push them to then ask the pharmacist "Hey, did you check the weight of my child against the medication?"
Right. Calling for a weight to the pediatrician's office is impractical. We would never add that to our colleagues. It is. And so I love Rachel's suggestion about having a scale if the child is present. Many times the child isn't present. So again, we are left with verbal, verification from the parent. But as I kind of stated earlier, it's so simple to print a growth chart up, or I'm sure there's an app where you can get a rough estimate, and using that 50 percentile is not wrong. Now, we have children on opposite ends of that spectrum, and whether they're grossly underweight or well above, what's recommended in terms of overweight. But again, I love what Justin said about why not try to make it safer and find progress in that. And if you're listening to this and you don't know how to use a growth chart, find my email. I will have a 10-minute conversation with you. That's all it will take to teach you how to use a growth chart. It's not a problem.
Amen to that. And Rachel will do it. I'll do it too as a pediatric faculty member myself. We'd be happy to show you how to do that. So as we start to wrap things up, I'd love to know, what is it going to take for us to get these changes to really be made? So I say that advocating for it in my state. Back in January of 2024, the Board of Pharmacy actually proposed a rule in the state of Ohio that read, for outpatient prescriptions for minors, which is defined as those under 18 years of age, all licensed prescribers must list the patient's weight for the outpatient prescription to be filled. The pharmacist literally could not fill it until they had a weight. Now, that hasn't gone into effect because it went into comment phase, and I believe the board dropped it because of the comments they received. And again, this is the only way to go about it, and maybe the language wasn't perfect, right? But it's an example of sometimes we can advocate and still things kind of don't move in the way we want them. So Lisa and Rachel, what do you think we need to do? How can we band together to support PPA and the other pediatrics organizations and med safety organizations that say this needs to happen?
I think, Justin, we need to get a hold of those comments and find our counter arguments. And so some other ones are, some meds don't need weights. Should we have exemptions like topicals, inhalers? Obtaining a weight, how often? At a pediatrician's office may not be easy. And so at what age does it matter where we just get an annual weight and that's acceptable? And I would argue that maybe it's around 3 or 4 where an annual weight would be okay. Prior to that, I need more often weights. It matters. I think telemedicine is more prevalent, how are you going to get a weight? So I come back to, we have scales in the home. And are we allowed to accept weights from not the physician, and pharmacists can get a weight from a caregiver? Is that acceptable by law? I would think that's acceptable, and it's better than where we're at today. So again, it's probably about the language and what we're advocating for, but I would love to hear, like, what are all the barriers, and let's squash them with solutions to those barriers.
I think we need to get some of the software companies on board that do some of the e-prescribing, to make sure, because I don't think there's even a field right now for weight. I remember I asked one of my students who works retail, and she said, we have a field for the parent's email, though. So we have their email address, but we don't have their child's weight. And obviously that needs to go along with the date that that weight was recorded, so that it's, we know what we're dealing with in terms of that number. But yeah, I think they're going to be a key player as well. And of course, getting other pharmacy organizations on board with this, I think, will help also.
So that was actually one of the comments, Lisa, that you said somebody rebutted, and I think it was the Hospital Pharmacists Association said, basically, well, what if it doesn't need a weight? And I said, that is fine. If you want to put that little disclaimer that if it's topical or one of the weird drugs like our antihistamines that don't require a weight, but I would argue, I don't know, even it's in that case I would want to know. But regardless, I think working with them to find a middle ground for some of these arguments is like at least better than nothing. And they were amendable once I said, yeah, I think that's totally fine to put that in the statement, if that's a concern. But most of the American College of, am I saying that right? The American College of Clinical Pharmacists, the ACCP, they've been more than willing to support us. And and I didn't get a formal letter, but the American Pharmacists Association is doing more and more things regarding pediatric stance. And so there are definitely many ways we could collaborate. And I think the biggest thing we could do until this actually starts to become a mandate is just continue to be the squeaky wheel and just talk about it all the time and be extremely annoying about it.
I think to wrap it up, does anyone else have any closing remarks, anything we want to let our viewers end this with?
Help us. Help advocate for it. Go, talk to your own state legislators like Jenna and Justin have done, and, talk to any group that you're a part of.
Rachel, Lisa, Jenna, thanks for joining us so much. It's been a great conversation, and my hope is that we are forwarding this conversation. And again, if any of you as listeners are passionate about this, please connect with any of us. We'd be glad to collaborate and move this forward. Let's get these weights on pediatric prescriptions. Thanks for listening to the Pediatric Pharmacist Review.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.